Hi, I'm Paolo Parini, and I'm a doctor and researcher at the Karolinska Institute and the Karolinska University Hospital. And it is a pleasure for me to talk about Familial Chylomicronemia Syndrome. These slides show you my disclosure, and for this presentation, I got an honorarium. I usually ask the person I see at the clinic and to my students why we have lipoproteins. We don't have those actually for transporting cholesterol to the body because each cell can synthesize it, but mainly we have it because we need to transport fatty acids to the body because fatty acids are used to produce energy. Fatty acids are molecules that are coupled to another molecule that's called glycerol, and they form triglycerides. Triglycerides are molecules that cannot be solubilized in water. To have an idea how triglycerides look like, it's enough that you look at the bottle of vegetable oil that you have in your kitchen, and that form is a soluble form of triglyceride at room temperature. Whereas when you look at the butter in the refrigerator, the butter is a solid triglyceride at the refrigerator temperature. Since our blood is a water-based system, triglyceride cannot solubilize like that. So during evolution, some biological systems have developed complex of molecules that are called lipoproteins. Lipoproteins are molecules or complex of molecules. They also contain lipids and other specific proteins that are called apolipoproteins. I always say that lipoproteins, they look like a pastry with a filling, where I have some lipid on the outer part, and those are free cholesterol and phospholipids, and some other lipids that make the filling of the pastry, and those are cholesterol ester and triglyceride. And cholesterol ester and triglyceride share a common feature. They are really apolar, means they don't have any charge on the surface. Lipoproteins are divided by size and density in several different classes, and you can see them here. Of course, we will focus on the chylomicrons. And I can just anticipate that chylomicrons are formed in the gut, whereas, for instance, VLDL lipoproteins are formed from the liver, and they will transform into LDL cholesterol. Maybe you have heard about LDL cholesterol, is what is usually referred as a bad cholesterol, whereas you have also HDL, usually referred as a good cholesterol, but HDL are mainly formed in circulation. So if you look at the chylomicrons are lipoproteins that are synthesized in the liver after a meal, and they can have different amount of triglycerides. Why they are called chylomicrons? They are so big that they are in the microns range, and the micron is 1/1000th of a millimeter, and they are called chylo because they are found in the lymph. They drain from the intestinal tract. As I said, chylomicrons have different variable amount of triglyceride, and this is very much in function of the amount of fat triglyceride that we have in the meal. Higher is the amount, higher is the what we call postprandial triglyceride that we found in the blood. They are synthesized in the liver. Their function is to deliver fatty acid to the peripheral tissues, and then they are taken up by the liver. And this process is very, very rapid. In a normal person, the half-life of this process is between 6 minutes. The half-life means that in 7 minutes, I reduce 50% of the amount of chylomicrons that I have produced at that specific time. Chylomicrons, as I said, the name itself, they are very, very, very big. They can go up to the micron in terms of diameters, so they cannot leave the vessels and go in the vessel walls and promote atherosclerosis. But they may promote an acute inflammation of the pancreas that is called pancreatitis. Chylomicronemia syndrome and familial chylomicronemia syndrome share a common features. There is a very severe hypertriglyceridemia, and this hypertriglyceridemia considers that it's possible to find chylomicrons in a fasting condition. As I said before, the process in synthesize the chylomicrons once they appear in circulations and they go to the liver is very rapid, minutes. It means that in a normal person after overnight fast, there is no chylomicron in circulation. That's why we ask also to leave blood after overnight fast. If the synthesis of chylomicron is not counterbalanced by the catabolism of triglycerides, breaking down the triglycerides, the process gets very much enlarged in terms of times, so that I accumulate chylomicrons also in a fasting condition. The chylomicronemia syndromes result from a cluster of minor genetic variants that cause hypertriglyceridemia. Instead, the familial chylomicronemia syndrome is a specific form. This is due to very rare genetic mutation in genes that encode for proteins, and this is the list of proteins that are of huge importance in the breaking down of the triglyceride that are inside the chylomicrons. But what is a genetic disease, and specifically what is a monogenic disease versus a polygenic disease? In each of our cells of the body, with the exception of the red blood cells, there is the nuclei, and the nuclei contain the DNA. The DNA itself contains the information needed to produce and synthesize the protein. And the DNA is organized in chromosomes. Inside the chromosomes, there are specific also regions that have a specific information to synthesize a specific proteins. These structures are called genes. And in our body, there are 2 copies of each chromosome. One originates from our father, biological father, and one from our mother. So we have, as I say, 2 genes, 2 copies for each chromosome. It means that we have 2 copies for each gene. When we have a copy of a gene, or the both copies of the gene that are mutated, and the body cannot compensate for this mutation defect in the sequences, then the disease occurs, and is called monogenic disease. So again, we said we have 2 copies of chromosome. In each chromosome, we have the genes. So we have 2 copies for each genes. And when one copy of the gene is mutated, we have a condition that we call the patient as heterozygous. When the same defect in the gene is present in both of the copy, we say that we have the patient is homozygous. But then I can have another condition when there are 2 different defects, either one of each presence in one of each copy of the gene, and this is called compound heterozygosity, whereas when 2 different gene defects are present in the same copy, is called compound heterozygosity, but cease. These 2 conditions may, from a clinical point of view, be exactly the same or lead to the same kind of problem. Then we have other concepts. One is called penetrance, and one is called expressivity of the gene mutation. And the penetrance refers to whether the mutated gene is expressed or not. How many people with the gene have the trait associated with the gene? If all the persons that are affected by the monogenic disease have that trait, it means that the penetrance is complete. That is only 50% of those have it, is 50% for instance, penetrance. Instead, the expressivity of a mutation determines how much the level of, say, disease is present in the single individual. So these 2 concepts are independent of each other, but they define the degree of disease in a single individual. Familial Chylomicronemia Syndrome is a disease that has several clinical manifestations and complications. We can see manifestation in the skin, and then we have eruptive symptoms. We can have manifestation in the eye, and we have accumulation of lipid in the retina. We can have enlargement of the liver or the spleen. Then we have hepatosplenomegaly, or if only the spleen is involved, we have just splenomegaly. But we can have also recurrent abdominal pain. And actually, this is a problem, also quality of life of the patients, independently of the pancreatitis. And as again, we can have pancreatitis that is acute inflammation of the pancreas organ, or recurrent pancreatitis during lifetime, then in the end create also chronic problem to the pancreas. As I say before, chylomicrons are lipoproteins that are synthesized in the intestine after the meal, and they contain variable amount of triglyceride. Higher is the quantity of triglyceride in the meal, higher is the postprandial triglyceride rise in the bowel. And this is also important, and this is one of the pillars why we advise for very low fat diet. And since, as I said, there is an imbalance between synthesis and how we break down, and the capacity, ability to break down the triglyceride and the chylomicron, one of the pillars of the approach to control and treat familial chylomicronemia syndrome is to reduce as much as possible the triglyceride content of the chylomicron. That's why we advise to use less than 20 grams fat per day. That's why also we advise to use medium chain triglyceride oil, because this leads to less formation of chylomicron-rich in triglyceride. This is also why I advise my patients to use oil, vegetable oil with a high content in unsaturated fatty acid, because we know that saturated fatty acid, monosaturated fatty acid actually promote a high content in triglyceride in the chylomicron. But also we advise to complete this diet with fat-soluble vitamin, like vitamin A, D, and K. And also we advise to give as a food additive magnesium and calcium. It is very important to do the diagnostic screening. And the reason why is because we have general population, we have hypertriglyceridemia, but the top of the hypertriglyceridemia, we have what we call the very high, severe hypertriglyceridemia. And this severe hypertriglyceridemia can be divided into major group of diseases. One is called the polygenic and one is called the monogenic. FCS is a rare autosomal recessive disorder. What does this mean? It means that the frequency is very low. It means that the genes that are mutated are present in those chromosomes that do not determine the biological sex, and it is recessive, means that I should have 2 copies of 2 gene defect in the 2 copies of the gene. It could be the same gene defect, but sometimes it's 2 different gene defects by the 2 different copies. And is characterized, again, by very high level of triglyceride. And the reason is because we have an impaired catabolism of triglyceride in the chylomicron. The polygenic form of chylomicronemia are instead due to the combination of different genetic variants that per se alone cannot induce the clinical picture or the disease, where accumulate very high level of chylomicron. This is very important. And it is important to how to manage patients with the FCS versus the polygenic form. And also it's very important to choose the right treatment for these 2 different conditions. It is also very important to identify the carrier of the mutations, because being a familial chylomicronemia syndrome, autosomal recessive disorder, the patient that is a carrier may give to the siblings 50% of the time the mutated genes. Or if it's a polygenic form, is a combination of different genetic variants. So the chance that all the different combinations, the same combinations given to the child is much less. Sometimes familial chylomicronemia syndrome is discovered in women when they are in the 3rd trimester of pregnancy. I myself been into times called by the emergency room because there was 2 women in the 3rd trimester that they were needed for emergency room because of an acute pancreatitis. You have to remember that during pregnancy there is a usual normal elevation in cholesterol and triglycerides, but this elevation in triglyceride is far away from being the elevation in triglyceride that we see in familial chylomicronemia syndrome. And this is due to the fact that there are kind of hormones like estrogen, progesterone, placenta, lactogen, and also to the fact that the body during pregnancy became less sensitive to insulin. Insulin is an hormone that help in the hydrolysis, in breaking down the triglyceride, help in the process that give to the fact that we can keep down the triglyceride, especially in the postprandial phase. One peculiarity of the third trimester is that in the estrogen level increase into the relation of progesterone, and this really can precipitate the condition. It's very important to know this condition in advance if the woman who is pregnant have a familial chylomicronemia syndrome, because if we know it in advance, we can take proactive measure in order to immensely reduce the risk of complication both for the mother and for the future child. I really want to thank you for listening to this presentation.